Hello, Prof. How are you?
Good, thanks. How are you?
Yes, I'm okay. So, you are seeing everyone?
What's that?
Can you see all of us?
Yes. I can see a large room of people. I'm just getting my slides organized. But yes, I can see a large room of people here. Absolutely.
Yes, thank you very much. Thank you joining us. So, we can start the session now.
Yeah, I can even see myself on the ceiling monitor facing me in the middle of the room. So I'm in good shape. Okay, well, thank you. Sorry I'm 2 minutes late. I was just trying to get through rounds quickly. I started earlier than usual to be done. Firstly, thank you for asking me to participate in your educational process. I'm happy to do so, and perhaps I'll see some of you when I'm in Chennai in a couple of weeks for our fourth.
I can understand it's a 4 o'clock in morning. You have wake up so early, and for
that's fine. That's not a problem. But looking forward to returning to India in a few weeks, and hopefully see some of your friendly, smiling faces down in Chennai. In the meantime, this morning, I'm going to share my screen and talk about the importance of
we are switching off the light so we can see your presentation on projector.
Okay, so you tell me when you can see my.
We are ready. Just start. We are ready there.
Okay, can you see my slides now?
Yes, we can see the importance of multidisciplinary care of rectal cancer.
Exactly. So that'll be the topic for my first lecture in this series, and it's my privilege and pleasure to be with you today. And at the center of multidisciplinary care, of course, is the patient, but many other specialties are involved in rectal cancer care. When I was a resident 40 years ago, the surgeon made a decision and occasionally called in other people like radiation or medical oncologists. But now the decision how to manage a patient centers around the patient, not the surgeon, and involves many other groups of specialists. The surgeon is still very important for the management of rectal cancer. And I'm going to review a few studies that show the huge differences in outcomes based upon surgeons. So this study back in 1998 compared 47 surgeons who were general surgeons with 5 colorectal surgeons for rectal cancer management. And the first thing seen is the colorectal surgeons tended to operate on more distal tumors. Despite the tumors being more distal, were more able to perform a restorative resection rather than an abdominoperineal resection. Well, you could say that's fine, but perhaps they weren't doing as good a cancer operation and were favoring avoidance of colostomy rather than cure of the cancer. But in fact, it was actually the opposite. Despite performing more restorative resections on more distal tumors, colorectal surgeons had lower recurrence rates and better disease-free survival rates. And when you look at how it marches out, the best possible outcome for the patient is to have their rectal cancer surgery by a colorectal trained surgeon who's performing a higher volume of procedures. And the worst possible outcome is a low volume, non-colorectal trained surgeon, where at this point, and these data are old, but they're not ancient, from 14 years ago, is having a non-colorectal trained person whose low volume is associated with almost a 50% recurrence rate, which is obviously clearly unacceptable. And in fact, in that study, the Canadians found that the hazard ratio for being operated by a general compared to colorectal surgeon was, just in line with perforating the tumor or neurovascular invasion. A little closer to home for you guys in the UK, as opposed to Canada, was the fact that patients with rectal cancer operated upon colorectal, in this case, operated by a general surgeon were 3.5 times more likely to develop a local recurrence than patients operated by a colorectal surgeon. And around the world, these same findings have been in the literature for many years, from Australia, from Les Bouquet, the Canadian study I showed you, Harmon in the state of Maryland, in Germany, Paul Hermanek, Callahan in New York State, Hao Wang, one of my alumni, looking at Chinese data, and so on, all around the world. Volume as well as specialty are associated with lower morbidity lower mortality, and lower rates of recurrence. So let's turn specifically to the development of our multidisciplinary care in the United States. And what we found, but Rocco Riccardi and a group, he was a resident at the University of Minnesota, and they looked at a study called the Nationwide Inpatient Sample, which is a 20% stratified random sample of U.S. inpatients over a 15-year period. And they found that there was an increase in sphincter preservation, but ultimately 60% of patients, 60% were undergoing a colostomy. And in a subsequent study, when Rocco graduated and moved up to Boston to the Leahy Clinic, he pursued this line of inquiry and did what's called a heat map. So looking at 21 of our 50 states, and then drilling down within each state to county level. So here's a blow up, for example, of one of our states. And in that state, what you can see is, and I believe this is Michigan, if I'm not mistaken, but in any event, looking at county levels throughout the United States. So there are 489 counties in his study. And he found that in most counties, 41 to 60% of patients walked out with a colostomy. In fact, there were some counties where everybody had a colostomy and very few with a low rate of colostomy. Is it possible that patients in the high stoma counties all had tumors invading their sphincters? Probably not. More likely it's related to volume and training. And in fact, to follow on with that, a year later, he published the fact that surgeons who were capable of performing restorative resections were more likely to be specialized in colorectal surgery. How do we know that? Because they're performing more pelvic pouch procedures and more anorectal surgery. In addition to sphincter preservation, the surgeons who only performed abdominal perineal resection, only, in other words, no restorative resections, their patients were twice as likely to die after surgery. So it's really a major problem. And what he found was that these high stoma counties tended to have, number one, very high rates of colostomy formation. I mean, 60% is crazy. Less likely to have an MRI or a PET scanner, less likely to have teaching hospitals, and certainly less likely to have. Okay, so we had the highest rates of circumferential resection margin positivity as well, which was also problematic. So these problems are not insurmountable. Here you can find rectal cancer, for example, in Sweden was improved upon by having centralized units of care, which in Europe are called centers of excellence. And by establishing those centers of excellence and limiting rectal cancer surgery to these centers, local recurrence rates decreased from 47% to 13%, and cancer-specific survival increased. Centralization of care in Denmark, Ken Smed, nearby in Denmark, also showed tremendous improvement. Sorry, that's still Sweden. Also Sweden, significant improvement. Denmark improved 5-year relative and overall survival, as well as in the Netherlands, in Spain, in Belgium, and many other countries. These centers of excellence were associated with better adherence to total mesorectal excision, less use of permanent stomas, lower local recurrence rates, and better overall survival. So given all of these issues combined, in 2011, we established a multidisciplinary group taking leadership from all of these different organizations and trying and also having leadership was diverse, geographically diverse, institutionally diverse. So big teaching hospitals, smaller private hospitals, all kinds, clinics, universities, all kinds of academic and community settings to try and represent the entire spectrum of rectal cancer care in the United States. And it wasn't just surgical organizations. We had the American College of Radiology and the College of American Pathologists with us. And we spent couple of years with what we call to action. So putting articles in the literature like this one in Annals of Surgery, Disease of the Colon Rectum, Colorectal Disease, JAMA Surgery, Annals of Surgery again, Journal of the American College of Surgeons, putting these call to awareness articles out so that people understood we have a problem in the United States and we need to fix that problem. So I presented it to the Board of Regents and officers for funding. And at that time, I was on the Commission on Cancer Accreditation Committee, and I'm on the Executive Committee. And at the time, I was on the board of regents for the American College of Surgeons. So the program was approved in 2014. We spent 3 years developing a standards manual, which we beta tested on 6 programs with beta test site visits in 2017, then put it out for public comment, and in 2018 officially launched the accreditation program. It's through the Commission on Cancer, which is a not only multidisciplinary, but also public organization. So in addition to 56, or within the 56 professional member organizations, are lay organizations like the Susan B. Komen Foundation for Breast Cancer and the Lance Armstrong Foundation, and many other groups, as well as tumor registrars and geneticists and many, many others within the COC. The data repository of the COC, which is jointly held with the American Cancer Society, that I mentioned to you, National Cancer Database, has over 50 million, at this point, over 50 million cancer records. It is the world's largest repository with over 250 data points per patient and over 50 million patients. Using that database, we found that despite the worst outcomes, repeatedly proven worst outcomes of rectal cancer surgery when performed by general rather than specialist surgeons, patients seemed agnostic. And in fact, the vast majority of patients in the US were treated in low and intermediate volume centers. And really only about a quarter of patients were treated in high volume centers, despite the fact that highest adherence to evidence-based treatment was in high volume centers. So patients weren't aware of this. And if they were, they didn't seem to care. We found a high rate of circumferential resection margin positivity with geographic variation. So we established this NAPRC, and I'm pleased to say that if you type into your browser NAPRC, we come up, National Accreditation Program for Rectal Cancer. Again, conceived in 2011, approved in 2014, launched in 2017 with a soft launch and a hard launch in 2018. The same societies continue the representation, and I'm sure you know many of these, if not all of these societies, and you can see it's multidisciplinary. We have 4 committees, an executive committee, an accreditation committee, education committee, and quality committee within the NAPRC. And the standards manual, the most recent iteration, was updated again after 2018, was updated in 2020, and we're again in the process of a 2022 refresh. But let me go through some of the standards which we practice to try to give, to fulfill our mission of affording the best possible outcomes to patients with rectal cancer throughout the United States. So the first is, or not the first, but one of the first I'll discuss, is that there's a minimum attendance. So the NAPRC requires the program have a director, which locally is me, you can have an associate director. We do here, Dr. Arun Nagarajan, who is a superb, he's our lead medical oncologist for colorectal cancer. We have our lead pathologist, Mariana Berho, who's was on the executive committee of the NAPRC and is our chair of pathology and lab medicine, and like me, a huge fan of India, and she'll be coming with me back to Chennai in 2 weeks. And all of these people, but you must attend. So we must discuss every patient. If you're going to be NAPRC accredited, you must discuss every patient with rectal cancer. You must meet a minimum of twice a month. We meet weekly to discuss every patient, and this is the mandatory attendance. And at those meetings, we review the diagnostic pathology and we offer staging. Everything is done according to a synoptic report. So the radiologist will review according to Gina Brown from the UK, from London. Gina's protocol was a little bit modified by the Cancer Care Ontario group in Toronto. And using these synoptic reports, we can give much better information than using free text, as I'll show you shortly. We report the CEA level, very important. And at the end of that, after we reviewed the biopsies, the CEA, the endoscopy findings, CAT scan of chest, abdomen, and pelvis, rectal cancer protocol MRI with synoptic report, we offer a treatment evaluation recommendation summary, which is sent to the referring physician, the primary physician, and the patient. But why a synoptic report? Well, the synoptic reports do give more information. And not only does the pathologist use a College of American Pathologists synoptic report, and the radiologist use Gina Brown's modified synoptic report, but we as surgeons must complete a synoptic report on every patient. But as I mentioned, it's much better to free text. Here are some very key variables in rectal cancer surgery, very important variables. We capture those variables 100% of the time in a synoptic report, but far less so in a free text report. So these are pathologists from Australia. But the same is true for us as surgeons. So Samantha Hendren in Michigan was one of the people who worked on developing our synoptic reports. And they did a pilot study from 10 hospitals in Michigan with 110 operative reports, and only 28% of the reports, when they were free text narrative, had all 24 elements we need within the NAPRC and the National Cancer Database. And then when the reports used a synoptic template, we got up to 92% complete. So Arden Morris took this one step further. She's out at Stanford, and this synoptic report for us as surgeons is within Epic, our electronic medical record, as well as within other EMR systems. And it's a pop-up. So if I type within my operative note .NAPRC, this report comes up. And each of these fields are pop-ups. So I can very, very quickly go through and ensure these 20 points are captured, including a narrative. So I can also dictate a supplemental operative report. So then there's no question we're all speaking the same language. Once that surgery is done, the specimen is assessed. We look at the photos, 4 different views, left, right, anterior, posterior. We look at the specimen that the pathologist puts on the big screen, and we review and we make a decision. What are we going to talk about for after surgery? Adjuvant therapy, not, follow, and communicate again. Every one of the people participating in this conference and this decision-making have to have completed the TME module by the American Society of Colorectal Surgeons. If it's a pathologist, the CAP and COC module, and if it's radiology, the American College of Radiologists. And the people who designed it, again, Samantha Hendren from Michigan for surgery, also Connor Delaney, our CEO here in Florida, president of the ASCRS. He started this committee for me when I was president of ASCRS. Scott Strong, who took it over. Mariana Berho, I mentioned already, and Judith Yee. So pathology and radiology, these are the reports. And again, just to hammer home the same issue, why is it important? Arden Morris did a follow-up study, and we did pre and post-implementation reports. And the bottom line is, we went from less than 50% reporting on these important variables to more than 89% using synoptic reports. So then we dictate our report, and then Dr. Berho shows us our pathology, and we do correlations. So it's not only educational for the surgeon, but for the radiologist too. So here you can see tumor invading the vesicle and the prostate, which on breadloaf section, you see the same thing. So it's great correlation. And this is a TATME specimen with an en-bloc prostatectomy. Here's one where you can see extramural vascular invasion on the MRI, and you can see it beautifully that Dr. Berho is showing us on the specimens. There's great correlation, and when this correlation doesn't exist, it's an educational opportunity for the imager. So the question is, how often does this change? We sit as a group, we mandate all these standards, we mandate attendance. Does it matter? Does it change outcome? So this is an interesting study published 4 years ago from Cleveland Clinic main campus. Now, nobody in this group is in NAPRC leadership. So there's no particular vested interest, conflict of interest in this group. But you can see that they collected all the rectal cancer cases presented over a year. They had 408 cases, and in each case, they surveyed people. So they said, you had your mind set what you're going to do with this patient in advance. So the surgeons here are Lucas Stokke, who's more of a junior surgeon, Ian Levy, very senior, David Liska, and then some mid-career like Emre Gorgon and Matthew Kalady. So a mix of junior, mid-career, senior surgeons. And they said, okay, you had your mindset what you're going to do. Then we went to this conference, we did a discussion. Did the outcome change? Did you change your management schema based on the wisdom of the crowd and that discussion? And in fact, yes, regardless of less than 10 to 20 or more than 20 years of experience, changes in treatment algorithm were found in roughly a quarter of cases. So it is important to have this wisdom of the crowd discussion, and they felt that their results supported the program, which is great. So are people really following this multidisciplinary care schema? So here's an anonymous questionnaire sent out to 328 institutions. A little over 40% responded. And in fact, the mean compliance with our 20 standards was 10, half the standards. Compliance was always best in high volume centers. And in fact, 100% compliance was achieved in only 4 centers. So plenty of room for improvement, even in the centers most interested in rectal cancer care. So that's what people say they're doing. Now, using the National Cancer Database, we can find out what people actually are doing. So NAPRC has the 20 standards. There are process measures like staging with rectal cancer protocol MRI with a synoptic report, like abdomen, pelvic, and chest CAT scan, so on and so forth. And then there are performance measures, like did you get a minimum of 12 nodes? Are your circumferential resection margins assessed? Are they free of tumor? They're negative, right? So we have these 2 different sets of measures. And what was found in the study was that all of the process measures were met in only 28% of cases, even in accredited institutions. And performance measures were a little bit better, up to 56%, but still lots of room for improvement and growth, and even in the most interested centers. So there's room for improvement, which will improve outcomes in patients. Who's most likely to do better? Again, it tends to be the higher volume hospitals. And again, here's yet another study showing it, that high volume hospitals had better 5-year survival outcomes than did lower volume hospitals. But again, only 2.9% met the threshold for all process standards, 16.7 on the 4 standards. So, this is a problem. We're committed to it, but it's not that easy to get it done. But we need to keep persisting. So then the question becomes, if you persist and if you meet the standards, are the outcomes better? So here's another study, which is now under peer review, where we had almost 114,000 rectal cancer cases. Once we got down to the ones for our study, we had about 49,000 cases here. And we looked at these various measures. This is tumor regression grade. And what we found here is that these standards were met, okay, had a correlation with outcome. All of these, when you met all of the process standards, clinical staging, again, rectal cancer protocol MRI with synoptic report, CAT scan, chest, abdomen, pelvis, serum CEA, tumor regression grading, circumferential resection margin assessed, proximal and distal margin, all measures assessed. Did we achieve these things? Well, still about the same as all the other studies have shown. Only 24% achievement of all standards. But we know if you achieve all these process measures, you have a hazard ratio that shows a reduction in local recurrence and an improvement in survival that is highly statistically significant. So, we did the math and we said, if we actually met all these standards in all of the accredited programs, we'd probably save about 300 lives a year in the United States. So you can actually start to put a number on what you can achieve by adhering to the standards. And, here's, looking at it graphically in a journal, American College of Surgeons, in another article we just published, we reviewed 25 programs accredited in the first 3 years, first cycle. The annual cancer volume per center ranged from 14 to over 200 rectal cancers a year. 2 programs out of 25 had 100% compliance. The range of compliance with our 20 standards ranged from 48% compliant to 100% compliant. The most frequent non-compliant were that all patients were discussed. Somehow people slipped through the cracks. or the surgeon says, you know, this patient, I got to operate, I can't wait for the meeting, whatever happens. And none of those things should happen, but unfortunately they do. All patients have to be discussed at the MDT within 4 weeks after definitive therapy. So here are the standards, how they're met. Here's the compliance measures. The ones that were compliant were here. So the good thing is every operation was performed by a trained surgeon. And I've hesitated. I've not said colorectal surgeon anywhere in this lecture because it could be a surgical oncologist or a general surgeon or minimally invasive laparoscopic robotic surgeon, but somebody who focuses on rectal cancer, who's doing it every day as one of their primary foci in their practice, because that's how the patient's going to get a better outcome. Year of accreditation, again, didn't seem to really matter. So programs initially accredited in 2018, in 2019, and in 2020, you know, maybe marginally worse in 19 and better in 20, but it didn't seem to really change. We currently have 45 accredited programs and programs actively in site review in the application process, another 28. So we get about 73 MDT programs in the United States. Our estimate when we were during our initial investigation period and creating the standards with David Winchester, the former medical director of cancer programs for the American College of Surgeons, we surveyed all 1,500 COC accredited hospitals in the US. We found that roughly 200 hospitals said they would be interested at some point in accreditation, and about 100 of those hospitals, 100 out of 1,500, said they would want to get accredited fairly soon. So we're almost at that number, and I suspect by the end of 2023, we should have about 100 accredited programs, which is right what we estimated, and then over time, more may join us. We're very pleased that we were one of the first, we were actually the second in the country, beta site tested hospitals who were accredited in the beta test survey. And then in 2018, we're again the second hospital in the country to be accredited. The first was a Sam Uman's program in Walnut Creek, California. So we're very happy to be in that group. So I hope that I've emphasized the importance of multidisciplinary team care, how that care improves outcomes for patients, and how even when we're in a country like the US, where we have lots of regulations and rules through the COC and the NAPRC and many other regulatory bodies, we still have room for improvement. But the theme throughout is that patients with rectal cancer do better when they're taken care of by an MDT approach, and patients do better from surgical outcomes when they're operated on by dedicated, trained surgeons who are performing rectal cancer surgery in a high volume. So the accreditation program is not available in India. However, the standards manual is. In fact, no COC accreditation program exists outside the United States. We hope someday to be able to accredit programs the way JACO approves programs and the way that the Committee on Trauma approves programs, but we're not there yet. But what you can do is access and download the module, the NAPRC module online to see the standards, and you can try and adhere to them. So if you have an interest in giving your patients these best case outcomes, you can do that without being accredited. And I know there are hospitals in Argentina, hospitals in Israel, and I believe hospitals in India that are trying to rigidly adhere to our standards without yet being accredited. So I hope I've given you some food for thought, and I've deliberately left time for questions and discussion.
It will develop, and we can have a completely multidisciplinary approach for rectal cancer. So it was very useful. Any other question you have?
I think it's very important, and quite honestly, in the United States now, we have the multidisciplinary approach for other things too. Inflammatory bowel disease, for example. For inflammatory bowel disease, we work with gastroenterology, pathology, radiology. For pelvic floor disorders, fecal incontinence, rectal prolapse, constipation, we meet with, again, radiology, gastroenterology, So many things we do are now multidisciplinary, not just cancer. And there is no accreditation for those things. So, but we still see the importance of joint decision-making, particularly inflammatory bowel disease and pelvic floor. So I think that it's something worth doing for sure. You don't need a formal accreditation process to give the patient the benefits of that MDT care. It's a matter of sitting down with your pathologist, your radiologist, your medical and your surgical oncologist and saying, listen, here's the evidence from all around the world. Let's do this at our hospital. Let's make, Laparoscopy Hospital the first one. Let's start out and sit together and give the best care for our patients. Even though we're not accredited, we know we're doing the best care for our patients. I think that's the starting point.
Right. Yes, that is very important. So thank you, Prof. Thank you very much for sparing your valuable time. And we will definitely see you next time. So,
all right. And I will definitely try to, for sure, I'll try and incorporate videos in future talks.
Yes. Thank you. Thank you very much.
All right. Thank you all.
Bye.
Take care. Bye.